All right, let's talk about some pulmonology. So aspiration pneumonia, that presents how fast? Was it the same day? No, aspiration pneumonia is not a same day. You know, the bacteria needs some time to build up and infiltrate and cause symptoms, so it'll be a few days. Treatment for the aspiration pneumonia depends on if there's any amount of sort of empyema or walled off gunky fluid like an abscess or a pocket of fluid like an empyema. If there aren't any of those things, then you don't need empiric anaerobic coverage. It's just okay to use cap coverage like ceftriaxone or zithromycin. You may need to do, drainage of any fluids or abscesses and amoxicillin, amoxiclav for any anaerobes. Also, treatment is prevent an aspiration in the future, so get a swallow study. Chemical pneumonitis, when does that present? That presents after a choking event on the same day, unlike aspiration pneumonia, which takes a couple of days. Treatment for chemical pneumonitis is supportive suction if it's witnessed. Other pulm crit things, symptomatic bradycardia. What's the treatment? You want to use IV atropine. Now, if there's for some reason unstable bradycardia, you want to do pacing. Hyper K in a cardiac arrest. How do you treat that? Calcium gluconate. Acidosis in a cardiac arrest. How do you treat that? Sodium bicarb. So calcium gluconate for K, sodium bicarb for acidosis. If someone had surgery and they suddenly can't move their leg, you want to think of a DVT and a PE. What kind of test would you get? You could get a CTA if they have normal kidneys. Could do a VQ scan if they have elevated QR. Now let's talk about VTs. Recurrent VTEs and clotting disorders needs anticoagulation, but for how long? It's long term. If it's provoked, it's 3 to 6 months, usually 6 months. DOACs, you need good kidneys to use DOACs. What's a good anticoagulant in pregnancy? You want to use heparin. Surgical embolectomy is used for failed thrombolytic therapy and if they can't be on anticoagulation. For example, right heart thrombus with a PFO needs surgical embolectomy. If you have an isolated calf DVT, the treatment is just serial imaging. If you have a superficial vein thrombosis, treatment is NSAIDs. If it's extensive enough, you might need anticoagulation for 6 weeks. And if it's recurrent superficial venous thrombosis, you might even need to do stripping. So strip the superficials if it's recurrent. Chronic PE history definitely needs a workup for CTEP with what kind of scan? The ventilation perfusion, VQ scan. And if you do have pulmonary hypertension, CTEF, then you can treat with riociguat. It's a soluble guanylate cyclase stimulator. It's used to treat pulmonary hypertension, chronic thromboembolic pulmonary hypertension, as well as pulmonary arterial hypertension. That's one of its first kinds in its class of SCG stimulators. Apparently, it works to vasodilate with the nitric oxide pathway. So pulmonary hypertension, nitric oxide. All right, if your INR is too high, then you want to, and you're on warfarin, then you want to reduce the warfarin. If you're bleeding on warfarin, you want to stop the warfarin and give the thing that warfarin inhibits, which is vitamin K. If it's serious bleeding, you want to give IV vitamin K and PCC or protein concentrate. Fresh frozen plasma will take a while, but you could do that or factor 7. And then you want to repeat the INR in 3 days and give more give more vitamin K to prevent the INR from rebounding up. How would you reverse warfarin or low molecular weight? How would you reverse heparin or low molecular weight heparin? Protein sulfate. Factor 10A inhibitors like fondaparinux. How is that reversed? Adenosine alpha. What type of tissue is affected by warfarin necrosis? And that's fat. Want to get protein CNS. Long-term complications of warfarin and heparin is osteoporosis. Don't use warfarin in pregnancy. However, I just got this board question in MixApp. Warfarin's okay below like 4. But in general, it's Strategen. After treating an acute VTE with anticoagulation, the best maintenance is Eliquis and rivaroxaban, which is a 10A inhibitor. You need good kidneys for DOACs, though. It's better than low-dose aspirin. Which anti-epileptic drug is associated with ITP? And that would be phenytoin. Iron deficiency anemia of ferritin less than 20 should respond to iron supplementation within a week. And you get a 2-point hemoglobin increase every 3 weeks with that. That's assuming everything else is okay. A one-time iron repletion is done with iron dextrin. But the side effect is what? It's anaphylaxis. Iron overload from transfusion does need chelation to a ferritin level that's below 1,000. Yeah, and you usually also want the transferrin low as well. Usually below like 40-something%. If you're having altered mental status, you want to intubate. If you have hypothermia, you want to warm the IV fluids. Remember, hypothermia can cause a lot of metabolic derangements. So if you have severe hypothermia, you need core rewarming, like warm oxygen, peritoneal lavage, versus mild hypothermia. Just you can do active external rewarming. So what is the therapeutic INR for VTE prophylaxis? It's 2 to 3, similar to aortic valve. Prosthetic aortic valve. You need it to be higher for mitral, 2.5 to 3.5. If someone is subtherapeutic on their INR level and they're admitted with a DVT or PE, then you want to give heparin and bridge them to warfarin. If someone is coming in with a DVT PE on a subtherapeutic dose, that does not mean that they failed therapy necessarily. You need them to be therapeutic and then have failed to warrant a failure of anticoagulation. And really, you can just try a different anticoagulant. But the test will probably say if you failed AC, then you should get an IVC filter. Treat low ferritin less than 30 and high TIBC as iron deficiency anemia, microcytic. Low TIBC, high ferritin, that's something that's inflammatory, like IBD, anemia of chronic disease. Acute complications of IVC, they're not benign. The IVC is a filter, but it could clot. Chronic side effects of IVC include recurrent DVTs. Actually, IVC in people with DVTs is common, and contraindications to anticoagulation like surgery, stroke, or bleeding is why you would get an IVC. Cancers may reoccur, so grab CT scans, especially medullary thyroid cancer. Why do you have platelet refractoriness? And that's because of HLA allosensitization. RBCs don't get that because they don't express HLAs, but platelets do. Mets to the mets of cancer to the bone pain, you want to treat it with palliative radiation. How do steroids work? They reduce prostaglandin synthesis. So that's good for reducing the tumor mass effect. Some more hem-onc stuff. So cancer treatment depends on the staging. So if you have lung cancer, you do need to do a CT. Lung cancer resection depends on the stage. Early stages are good to resect. Resection also depends on the baseline lung function. They may need some chemo. Blood transfusion reactions. So the most common is febrile hemolytic, and that's due to cytokines. That's the cytokines in storage. Acute hemolytic, that's secondary to ABO incompatibility. You want to get types and crossed. Urticarial, it's the recipient IgE against the donor. Anaphylactic is the recipient IgA against the donor. Trolley is donor anti-white blood cell antibodies against the recipient. And that can be treated with leukoradiation. And it's different from TACO, which is not immune related at all. That's a pure fluid overload. You can also have an amnestic response, which causes delayed hemolytic reactions. Continuing some hem-onc themes, if you have chemotherapy, anthracycline, heart toxicity, that causes what? Reduction in EF, and this is dose dependent, and it will cause a dilated cardiomyopathy. This is different from trastuzumab, which is dose independent. Radiation can have side effects on the heart as well as chemotherapy. Side effects include pericarditis, restrictive cardiac disease, MIs, conduction defects. What do thalassemias look like on iron studies? Do they look like anemia of chronic disease, which is high ferritin, low TIBC? Or does it look more like an iron deficiency anemia, which is low ferritin, high TIBC? So thalassemias, they look like anemias of chronic disease, high ferritin, low TIBC, but as opposed to anemia of chronic disease, it has high what? It has high transferrin. The treatment of anemia of chronic disease is to treat an underlying condition. It is possible that you might have to give EPO, but only if their iron reserves are replete. Treatment for GBS, MG, and TTP, Guillain-Barré, myasthenia gravis, and TTP can be treated with plasma exchange. That's because they're all antibody-driven, immune diseases. So you want to get rid of the autoimmune antibodies. Now, what is the treatment for autoimmune hemolytic anemia and hereditary spherocytosis? That is a splenectomy. So splenectomy for autoimmune hemolytic anemia. Myasthenia gravis crisis, you want to use plasmapheresis. Hemophilia A is X-linked recessive. That means that it is exclusively in men, and females are the asymptomatic carriers. If you have a carrier mom, the son has a 50% chance of being affected. And if you have an affected dad, how many of the daughters are going to be carriers? All of them, because it's X-linked. So if he has a daughter, they will all share one of his X's. All right, that was a bit of a tangent on hem-onc, but let's get back to pulmonology. If you think of ARDS, you want to think of ventilator-associated pneumonia, increased secretions, worsening pulmonary infiltrates. If it is suspected, you want to get a sample of the vent-associated pneumonia. So you want to get endotracheal or tracheal bronchial aspirate. You want to start empiric antibiotics with Pseudomonas and MRSA in mind, so Vancomycin. You can narrow it down later. If no improvement, then you want to look for something persistent like an empyema or abscess. Consider fungals or other atypicals like PCP. You want to prevent ICU complications, aka ICU liberation. Liberate the ICU. So you want to do sedation holidays and spontaneous breathing trials. Early PT, nutrition, swallow evals, minimize delirium inducing. Instigators want to have good sleep-wake cycle, remove any lines, tubes, or drains that you don't need. You want to prevent DVTs and PEs, get family support, spiritual care. And remember, it doesn't end after you leave the ICU. You could have post-ICU syndrome, right? Psychiatric issues, depression, dementia, issues with physical mobility. Many can't work again. You still want to get reversible causes worked up. So TSH, B12, B9. If you have recurrent bacterial infections, sinusitis, pneumonia, what kind of immuno deficit could you have? It's something wrong with your humoral immune response. You want to check what in the blood. The antibodies, levels of IgG, as opposed to innate defenders, which are cells on the front lines like neutrophils or macrophages. Macrocytes. An example with early congenital recurrent bacterial infections is something like cystic fibrosis. So in those folks, you want to cover them with cefepime for Pseudomonas. What would the VQ show in COPD? The VQ would be low. What kind of VQ would you have in emphysema? You'd have a high VQ ratio, because there's lots of ventilation, just fine, but it's dead space. There's a lot of ventilation, but there's no Q, there's no perfusion, because there's alveolar interface destruction. It's a big floppy bag. Right to left heart shunts are not helped with oxygen, because you're bypassing the lungs entirely. You're just going straight to the system. So giving more oxygen to the lungs doesn't matter, because the right to left heart shunt won't get to the lung, so it won't get to the oxygen. You need to intubate for airway obstruction or even just impending airway obstruction. So inhalation injuries, soot, you want to get a laryngoscopy after a burn or chemical exposure to see what's going on, because if there is signs of soot or something that is impending edema, you want to intubate. Definitely if there's tracheal deviation, hoarseness from any mass effects. If pulse ox is showing 75% and then it improves to 82% with a non-rebreather, and there's tachycardia, and you're not able to protect your airway, you want to intubate. That's not good enough, so we want to intubate. Pulmonary nodules, there are some good features to pulm nodules, and there's some bad features. Good features, are symmetry is good. Symmetric is good. Popcorn is good. So popcorn symmetry is good. If it's diffuse, homogeneous, and it's laminated and it's central, that's okay. Problems are when it's bad features. Being eccentric is bad. Being asymmetric is bad. Instead of being homogeneous, if you're all over the place, you're reticular, you're punctuate, if you have hard axillary nodes and hoarseness, these are bad signs. So other things, pulm crit-wise, mitral regurg, associated with what sided MI? That's right-sided MI. Heart block is associated with what pole of heart block of a heart attack? That's inferior. Pulmonary embolisms can cause pulmonary hypertension. That causes right ventricular dysfunction, tricuspid annulus dilatation, and so essentially you can get tricuspid regurg. And I think that's also holosystolic, just like MR. What's the most common cause of asthma? It'd be an allergen to dust mites. That's right. Dust mites, most common cause of asthma. How is this diagnosed? You want to get pulmonary function tests. You can either do, just like stress testing the heart, you can stress test the lungs. So there's analogies in medicine everywhere you look. You can stress test the lungs with exercise, if they're able to do it, or you can use medicines. Do a bronchoprovocation challenge. Greater than 15% change in FEV1, it's pretty diagnostic. So FEV1, 15%. FEV1, FEV, 15% change. So how do you treat mild acute asthma exacerbation? You want to dilate the bronchioles, so you use a bronchodilator like a SABA. You can use steroids for about 5 days. How do you maintain treatment for asthma in the chronic phase? A long-acting muscarinic antagonist like tiotropium. How would you treat asthma in pregnancy? You want to use bronchodilators. You can use inhaled LAMAs like tiotropium. You could also use systemic steroids. And remember, pregnancy causes a respiratory alkalosis. So a relative acidosis in an asthma attack is actually bad, right? Because that means there's impending respiratory failure. That is an indication for airway protection, intubation. It needs prednisone if the inhalers don't work. And you might even use mag sulfate or terbutaline. And connection with OB-GYN. So if you do have something, if you do have uterus bleeding, you want to contract the uterus with oxytocin. You might even be able to use methylorgonavine or carbaprost. But carbaprost is a synthetic prostaglandin that stimulates uterine contraction, but it can also cause bronchoconstriction, and asthma would be a contraindication to use in this case. Okay, so if you have moderate to severe asthma requiring hospitalization, if there's signs of respiratory distress, so excess muscle using, trouble speaking, most common trigger is viral. And if you've tried a short-acting bronchodilator, a long-acting like a TO, you might need intubation, especially if you've already tried other adjunct therapies like mag sulfate or IV steroids. And an exacerbation, by mathematically how much peak flow drop there is, it's greater than how much percent? It's 20%. And asthma is common, but it's not uncommon to die from. So it is an emergency. As a correlation to cardiology, asthma may have the same decrease in systolic blood pressure that you see in cardiac tamponade or constrictive pericarditis, and that's pulsus paradoxus. So a drop in blood pressure due to the right ventricle bowing into the left ventricle during inspiration. If you have a young male with rhinitis, heartburn, painful swallowing and eating, and asthma, you might consider eosinophilic esophagitis. Eosinophils are also associated with asthma, so don't forget eosinophilia, commonly Addison's, cancers, asthma, allergic reactions, transplant patients, parasitic infections. Asthma, it's a hypersensitivity. So, it's histamines and leukotrienes that have been released after IgE cross-linking. So that's why you can treat things with montelukast. Again, what's the treatment for refractory, severe, persistent asthma? SABA, LABA, and high-dose steroids. Remember, you cannot give LABA without steroids. That will increase mortality, and that is always the wrong answer. If a patient is on a LABA, they must be on steroids, period. If the patient's already on a LABA and inhaled corticosteroids and more treatment is needed, you can do what to the steroid dose? You can increase it, or you can transition to oral. That's what's done with severe persistent or refractory cases. It's not really a class, severe refractory asthma isn't really a class of asthma, but the point is you want to increase it to orals. So what are the classes? There's intermittent, there's mild persistent, moderate persistent, severe persistent, or refractory. The separation is based on how often, the frequency. So if it's infrequent, it's intermittent. If it's mild, it's less than once a day. Moderate, it's at least once a day. If you have severe, then it's frequently at night, whereas the other ones are infrequently at night. And again, refractory, you want to start PO steroids. How often do symptoms occur in intermittent asthma? Again, not often. You want to start with a SABA, and you can always step up. SABA with inhaled corticosteroid, that's now becoming more frequent. Always give ICS with LABAs. Remember, asthma is a reversible obstructive lung disease because of the hyperresponsiveness to the lungs, because of inflammation. And the cause of inflammation can be allergens, it could be exercise, it could be GERD, even emotional stress. Even medicines can cause it. Beta blockers, NSAIDs. Again, dust mites, risk factors, history of atopy. And it's not benign, right? It could lead to respiratory failure, especially if you have respiratory acidosis, low PaO2, low pH, and a high CO2. So intubation, mechanical ventilation are indicated with severe asthma, unresponsive to maximal medical therapy, the SABA, the LABA, steroids, mag sulfate. Some of the PFTs in asthma as compared to COPD. So COPD is not usually reversible, whereas asthma is reversible. Late stage COPD is usually definitely not reversible. Asthma, again, is the drop in FEV, 15%. Chest x-rays will usually be normal in asthma. DLCO, diffusion, is usually normal or even high, whereas in COPD it's low, and x-rays will have hyperinflation. Just going back real quickly to the eosinophilic esophagitis. Treatment of that is what? Acid suppression. You may need to do a procedure if the PPIs aren't enough, like an endoscopy. A diagnosis is confirmed with how many eosinophils per high power field, greater than 15. And adjunct therapy could be steroids. So asthma, childhood disease, usually hyperactive airway, bronchospasm, inflammation. Could give anti-inflammatory antibiotics, bronchodilators, terbutaline, things that will block the inflammation. Beta-2 agonisms like terbutaline. You want to give positive airway pressure. If there's severe exacerbation, might need to do intubation. If there's worsening signs of confusion, respiratory acidosis, wheezing, difficulty getting air movement, you don't really need racemic epi in asthma. That's more for croup. You could do inhaled corticosteroids for long-term management. You would need to do orals, though, in asthma exacerbation. And in COPD, inhaled corticosteroids might reduce frequency of exacerbations and improve symptoms, but they don't. Inhaled corticosteroids don't have an impact on COPD. Systemic steroids do, but not inhaled for acute COPD exacerbation. And just while we're talking about inflammation and the cytokines that cause cellular immunity, so IL-1 causes fever. It's secreted by macrophages. It activates endothelial expression of adhesion molecules, Um, IL-2, it's secreted by all T cells. It stimulates growth and survival of T cells and natural killer cells. Interleukin-3, that's stimulates the growth and differentiation of bone marrow cells, also secreted by all T cells. Interleukin-4 comes from Th2 cells, and that helps the differentiation of helper T cells, as well as class switching between IgE and IgG, and promotes B cell growth. In fact, Dupixent inhibits this, IL-4, and is just approved for eosinophilic esophagitis. IL-5, that's eosinophils, and IgA class switching. IL-6 also stimulates fever and causes increased acute phase proteins to be produced in the liver. IL-8 is the chemotaxic for neutrophils to the site of infection. IL-10, it decreases expression of MHC molecules, and it decreases the inflammatory response. It inhibits macrophages and dendritic cells, and it's released by the regulatory T cells to kind of dampen down the inflammation caused by ILs 1 through 8. Interleukin-12, secreted by macrophages, promotes differentiation of T cells into Th1 cells, and it activates killing through natural killer cells. Interferon gamma, released by Th1 cells, helps promote and activate macrophages, promotes granuloma formation and natural killer cells, just like IL-12. Tumor necrosis factor alpha, released by macrophages, that could be in that granuloma formation that interferon gamma helped out to create. TNF alpha alters the vascular endothelium to promote leakage. So, you need your IL-1 to activate the adhesion. You need your TNF alpha to activate leakage. Also induces fever, promotes leukocytes to get to the site of release. And then interferon alphas and betas, they help. They're on all cells, and they basically activate the antiviral defense system of all cells. If you have end-of-life care, then you want to control pain with opioids, as well as air hunger. Could use anticholinergics, could use scopolamine, especially for all the secretions. Cooling fan, antiemetics, appetite stimulants. If there's delirium, you can treat with benzos. How would you treat carbon monoxide poisoning? You want to get a lab and do an intervention. So the lab you want to get is the ABG. See how bad their respiratory status is in their blood, and the carboxyhemoglobin level. And you don't want to get a pulse ox, because carbon monoxide will fool your pulse ox into thinking they're 100% when really they're not. You want to treat with a non-rebreather mask, plus or minus hyperbaric oxygen. And remember, carbon monoxide poisoning presentation is funny, okay? It can mimic. Carbon monoxide is the great mimicker. It can present as an MI, or seizures, or syncope, or coma. It'll cause lactic acid release, which will create acidosis, anion gap. Medicines with weird side effects that might be just as weird as carbon monoxide poisoning include amiodarone, but that's with prolonged therapy. It affects the heart with arrhythmias, the lung with pneumonitis, interstitial lung disease, lung toxicity, DILI. You would want to discontinue it and start steroids if that happened. Continuing with lung stuff, so we started with CAP. Let's end with CAP, but in an atypical way. So atypical CAP is caused by infectious agents that might not be seen on gram stain and cannot be cultured with standard medias. And so these weird guys are mycoplasma, chlamydia, Cetaceae and pneumoniae, Coxiella burnetii, Legionella, and viruses. Risk factors for the Coxiella pneumonia is exposure to animals. Risk factor for chlamydia Cetaceae pneumonia is exposure to birds. And risk factors for mycoplasma is crowded living or working spaces, dorms, military barracks, shelters, Mycoplasma pneumoniae is in fact the most common cause of an atypical CAP. If you have a patient with bronchiectasis on physical exam, they may have wheezes or rhonchi, depending on the cause. This might be heard even not when they have an acute attack. Chronic cough will usually have sputum and dyspnea. Again, carbon monoxide can be associated with automobile exhaust, but could also be inadequately ventilated areas with heaters, especially in the winter. And also methylene chloride ingestion, which is converted to CO in the liver. Pneumonia that occurs early in life, listeria, GBS, gram negatives, and CMV. COPD is a chronic obstruction that interferes with normal breathing, obstruction of airflow, and is not fully reversible. Distinctly, it could either be emphysema or chronic bronchitis. Emphysema, again, destruction of the airspace walls, so you have great ventilation but terrible perfusion, so it'll have the high VQ ratio. It's permanent enlargement of the acini. And when there's also airflow obstruction, that's classified as COPD. Chronic cough, lasting greater than 8 weeks, often COPD, bronchitis, postnasal drip. A solitary pulmonary nodule is a well-demarcated opacity less than 3 centimeters in size that presents without any associated effusions, adenopathy, or atelectasis. Small cell cancer of the lung associated with paraneoplastic syndromes like SIADH, Cushing's ectopic, ACTH. It's going to be ACTH high. You can have neuropathies, Lambert-Eaton, dermatomyositis. Small cell lung cancer, similarly to squamous cell lung cancer, are mostly central. Because small cell is highly mitotic and undifferentiated, they're very sensitive to radiation and chemo. And surgery is usually not effective for small cell. Pleural effusion is a fluid collection between the parietal and the visceral pleura. A pneumothorax is a collection of air in the pleural space between the lung and the chest wall. How do you define respiratory acidosis on ABG? It's a serum pH less than 7.37, and an increase in PCO2 greater than what? 45. Alkalosis. How do you define alkalosis? pH greater than what? 7.43. And a decrease in CO2 less than what? 35, right? So 737 and 7.43 is the range for pH, and then 35 to 45 for CO2. All right, don't forget your sleep apneas, repetitive cycles of hypoxia. This could be either central, obstructive, or mixed. The most common cause of bacterial pharyngitis in children, group A strep. Adults, usually viruses. Infectious diseases in CAP that are typical: strep pneumoniae, Klebsiella, Pseudomonas, staph, Haemophilus. In the absence of mitral valve disease, a patient with clinically significant tricuspid stenosis might present with fatigue, systemic venous hypertension, characteristically out of proportion to the dyspnea. Acute bronchitis usually is self-limited, caused by viruses, parainfluenza, less commonly something like mycoplasma or chlamydia or bordetella, pertussis. Risk factors is the winter months, right? That's where mycoplasma hangs out. Cigarette smoke, intubation, COPD. If you have an inherited defect of a protease inhibitor, that can cause emphysema and liver failure in a young person. That's alpha-1 antitrypsin. Defect in a protease inhibitor. So they'll have panacenar emphysema, coagulopathy, portal hypertension, high sag, encephalopathy, paniculitis. The degree of the phenotype depends on the genotype. So PIMM is normal. PISM, reduced levels but no symptoms. PISZ is reduced levels and predisposed to lung disease. And PIZZ is completely absent or almost no protein, and that's the highest risk for disease. It's inherited in an autosomal codominant pattern, which means it requires both the M alleles to make alpha 1. You want to check the levels of alpha 1, do a chest x-ray or CT scan, and PFTs will show an obstructive lung, which is reduced FVC and an FEV to FVC ratio less than 80. You want to treat this basically by infusing pooled human alpha-1 antiprotease. You want to replace the enzyme. You might need liver or lung transplants depending on how advanced the case is, and you must avoid cigarette smoking. Otherwise, you can get complications of emphysema, pneumonia, cirrhosis, respiratory failure. What is atelectasis? It's collapsed lung, basically a decrease in lung volume because of lung tissue collapse, secondary to, intubation, lack of a cough reflex, could be in a pneumonia, tumors, foreign bodies, could be due to pain after surgery, sickle cell crisis. Something that's obstructing, like a mucus plug, can cause alveolar collapse, or some sort of air or fluid pressing on the pleural cavity. Again, physical exam, the lung is collapsed, so when you tap on it, it'll be dull. You'll have decreased breath sounds, and if there is any airway, it'll have crackles when you listen to it. X-ray, you'll see some sort of fluffy infiltrate, tracheal deviation possibly, and a raised diaphragm if it's in the lower lobes. Treatment is incentive spirometry. You want to stretch the lung, deep breathing, ambulation, and if there's concern for an obstruction, you might do IP, you might do bronchoscopy. And complications of this collapsed lung is just like in medicine. If you have an obstruction, you could get an infection at the point of stasis, so pneumonia. Could get damage to the lung and in respiratory failure. In CF, pneumonias early in childhood, Haemophilus and Staph aureus. Later in early adulthood in life, you'll have Pseudomonas. The treatment of CF depends on the severity and the mutation, but it usually includes SABAs, hypertonic saline, chest physio, Dornase alpha, prophylactic antibiotics, high protein, high calorie diet, pancreatic enzyme replacement. Hemothorax, remember that parietal space between the parietal and visceral pleura could be a collection of blood due to trauma, due to malignancy, tuberculosis, dissection via aorta. You'll have dullness to percussion, decreased breath sounds. It'll be seen with blunting of the costophrenic angles on chest x-ray. You'll need to first resuscitate anyone with a hemothorax, but then definitively treatment is to place a chest tube, drain the 1.5 liters of blood, and that's considered a massive hemothorax. And if there's incomplete or inefficient drainage of the hemothorax or a retained hemothorax, that is a problem because, again, retention of fluids where they're not supposed to be can cause an abscess, empyema, tinnitus for infection. You usually see these folks coming in about a week after a chest tube removal, and they'll have fever, they'll have shortness of breath, chest pain, and with retained hemothorax, you want to do surgery, so a VAT surgery to remove the clotted blood. So if you're suspecting histoplasmosis, you want to get an enzyme assay in the serum or urine. Tissue biopsy shows granulomas. If it's in the lungs, it may look like TB with calcified forming target lesions. It might even spread to like the spleen or liver, have calcifications all over on CT because of the granulomas. You'll have high calcium. Supportive therapy if you're asymptomatic with histo, as it's usually self-limited, especially if you're immunocompetent. But with symptomatic histo or immunosuppression, you want to get hospitalized and treated with amphotericin B, especially if it's disseminated. And if it's not bad enough to be hospitalized, you can use itraconazole, which is similar to aspergillosis treatment. And again, induction with fungus infection as well as maintenance. So you want to treat for about a year after that too. If you have someone with IPF, pulmonary fibrosis, and then you want to do prophylactic vaccines like flu and pneumococcus, as well as pulmonary rehab and supplemental oxygen. If you have someone with laryngitis, which is inflammation of the larynx that lasts for less than 3 weeks, usually after a viral infection or vocal overuse or a bacterial infection, then if it's over 3 weeks, that's classified as chronic laryngitis. Same risk factors, but could also be GERD, reflux, irritation from chemicals, irritation from smoking, alcohol, and diagnosis usually clinical. But if it's chronic, acute usually clinical. Chronic laryngitis, though, that needs visualization. What is going on? You need to visualize it with laryngoscopy, just like you would if you had burn exposure and you needed to see if there's impending edema. If it's acute, usually self-limited, just supportive care, warm liquids, humidifiers, vocal rest, lozenge. And if you have chronic laryngitis, I usually want to treat the underlying condition. Smoking cessation, GERD therapy, antibiotics. Left untreated, chronic laryngitis may result in permanent loss of voice. Could cause the infection to spread. And if there's respiratory obstruction, you might even need intubation. Let's talk about lung cancers. So lung cancers, there's many different forms, and they occur most commonly as adenocarcinoma. Other things could be squamous cell carcinoma, small cell, large, metastatic, or other. Risk factors include smoking, products of secondary hand smoke, asbestos, or radon. Carcinoma of the lung is the most common killer of men and women today in terms of cancer. They can present in a wide variety of ways, including just cough and dyspnea and weight loss. Could also be paraneoplastic syndromes. First step in working up lung cancer is what imaging? CT. If you have someone coming in with recurrent pneumonias, you want to consider that they're not able to clear an infection because of some sort of cancer. Definitive treatment is you need tissue. Tissue is the issue. So you need to get a biopsy with an EBUS, especially if it's well localized, like a central tumor. In tumors that can't be accessed, if it's peripheral, like adeno, you could use VATS to obtain a tissue biopsy. Remember, VATS is something used in a retained hemothorax. Complications of the cancer include mass effects, chronic effusions, pleural effusions, and metastatic disease. Some of the mass effects that they might test you on is Panco's tumor, which is the superior sulcus. That affects cranial nerves C8 through T2, so that causes shoulder pain, Horner syndrome. Again, Horner syndrome is the cervical sympathetic chain, so that'll cause unilateral anhydrosis, ptosis, and meiosis. Sympathetic does dilation, mydriasis. So the opposite of that would be meiosis and pinpoint pupils. Or mass effects from superior vena cava syndrome. So facial fullness, JVD, head, neck, most common with small cell. And lung likes to metastasize to the brain, to the bone, to the liver, to the adrenal glands. And that's just like Miss L. Treatment for lung cancer, it depends on the type and the staging. Small cell, you don't do surgery, you do chemo and radiation. Could possibly even do lobectomies or VATS. But lobectomies, it's only indicated if the post-operative FEV1 prediction is at least what amount of milliliters of volume, and that's 800 milliliters. Lung cancer is very poor prognosis. 5-year survival rate is only 10%. Worse if it's metastatic. Surgery is only used to treat the symptoms if it's metastatic. What's the tumor of the visceral or parietal pleura? That's mesothelioma, associated with asbestos, but interestingly, smoking does not increase the risk of mesothelioma in asbestos workers, which is in contrast to the effect of smoking and asbestos on primary bronchogenic lung carcinoma. Most common presenting symptoms of mesothelioma are chest pain, shortness of breath, recurrent pulmonary effusions for no reason. And that makes sense because it's in the visceral or parietal pleura. You want to get a tissue. Chest x-ray will show the pleural effusions, pleural thickening. You need aggressive surgical, chemo, and radiation. Either way, though, it has poor prognosis. So mechanical ventilation, you should know that the goal FiO2, or inspired fraction of oxygens, you want to give less than 60% to minimize oxygen-free radicals. 100% FiO2 is unnecessary. The ideal tidal volume is 8 to 10 mils per kg of ideal body weight. You can control the CO2 with the tidal volume and respiratory rate, and you can control the O2 with the FiO2 and PEEP. So complications of ventilation include VAP and tension pneumothorax. Remember, with VAP you want to get the BAL. Tension pneumothorax, risk of barotrauma is associated with the additional PEEP. PEEP is the end expiratory positive pressure, and it serves to keep the alveoli from collapsing on expiration, which keeps them open for longer to do gas exchange. However, complications of high PEEP include the barotrauma, include intracranial pressure, and include hypotension from diminished venous return. So mechanical ventilation will in effect, with high enough PEEP, will decrease your blood pressure. So we had effusions lining the pleura and mesothelioma of the pleural lining of the lungs. But you can also have just inflammation of the lining of the lungs, and that's called pleurisy. Again, as with most inflammation, it could be caused by an infection like viral or bacterial like TB. But inflammation is not always infection, right? It could be autoimmune, pleurisy from lupus or rheumatoid arthritis, hypersensitivity pneumonitis, or even a PE can cause pleurisy. These are knife-like stabbing pain upon inspiration, worse with breathing. Because of the pain, you might have tachycardia. Because of the inflammation of the pleural viscera, you might have friction rub on auscultation, and on history, a recent URI. Diagnosis is clinical and an X-ray to rule out other etiologies. The management is supportive. treat the underlying condition, and could do NSAIDs. Talking about lung fibrosis, generally, it's some sort of occupational exposure. Could also be fungal. This is stuff like asbestos, silicosis, coal workers, berylliosis, talc. They usually have an occupation risk, shortness of breath, tightness in the chest. And usually early on, completely normal exam, but PFTs will show an obstructive or restrictive process with decreased diffusion capacity. It's even worse if you have exposure to smoking, and you can be considered for a lung transplant if your PaO2 is less than what with oxygen therapy? Your PaO2 is less than 60. Kaplan syndrome is this association with pneumoconiosis and what disease that's inflammatory that can cause pleurisy, and that's RA, rheumatoid arthritis. Again, asbestosis has pleural thickening, lower lobe infiltrates. On biopsy, you'll see the patchy dumbbell-shaped iron bodies on histology. That's classic. Bronchogenic carcinoma is in fact the most common cancer associated with asbestosis, not mesothelioma. And mesothelioma does almost exclusively occur after asbestos exposure, but it's not the most common cancer associated with asbestosis. The most common cancer associated with asbestosis is bronchogenic carcinoma. Silicosis will show nodular or rounded opacities, less than 1 centimeter. These also usually happen in the upper lobe as opposed to asbestosis in the lower lobe. And berylliosis, X-ray findings will be pneumonitis, pulmonary edema. Chronic berylliosis can have septal thickening, ground glass opacities. And what's the diagnostic test for berylliosis? And that's a beryllium lymphocyte proliferation test. Treatment is steroids for most of these. What's the treatment for cryptogenic organizing pneumonitis, or COP? And that's also steroids. If you have acute pulmonary edema, you can actually see EKG changes like QT prolongation or T-wave inversions. X-rays of pulmonary edema will show the consolidations, the cephalization of vessels, and the curly B lines. Empyemas is purulent fluid collections, again, in the pleural space between the parietal and visceral pleural. Pulmonary hypertension can be either cardiac or lung or they could be clots or idiopathic. Usually pulmonary hypertension will have some sort of valvular disease. On X-ray, you'll have RVH, enlargement of the PA. EKG will show RVH, peaked P waves, right axis deviation. Treatment includes oxygen, exercise, anticoagulation, might need diuretics and digoxin. A rare form of interstitial lung disease that is affecting mostly young adults, associated with tennis racket Burbeck granules, S100, Langerhans cells, and that's pulmonary Langerhans cell histiocytosis. Complications of this include spontaneous pneumothorax because of the lung inflammation in the interstitium, as well as diabetes insipidus. This is seen on CT as multiple cysts and nodules, usually in the mid to upper lobe. And stellate lesions extending into the lung parenchyma is the characteristic histopathological Langerhans cell histiocytosis lesion. Treatment includes smoking cessation, steroids. Unfortunately, have limited value. Sarcoid, you'll have non-caseating granulomas in multiple organs, notably the lungs. Usually this resolves on its own, but you might need to treat with steroids, and if they're refractory to that, you can use methotrexate, stops folic acid, infliximab, or even a lung transplant. Cardiac sarcoid, from most to least common, manifests as heart block, usually third degree, or ventricular arrhythmias like VTACs. Lab abnormalities include elevated levels of ACE, gamma globulins, lots of calcium, increased levels of vitamin D, alkaline phosphatase if there's liver involvement. And on chest x-ray, you'll see the bilateral hilar lymphadenopathy. Again, asymptomatic, non-progressive sarcoidosis usually does not require treatment and will have spontaneous remission. But if it's symptomatic or progressive, you definitely want to treat this. And these are non-caseating granulomas. Sinusitis, again, viral, commonly associated with URIs. Can also be caused by obstructions, nasal polyps, deviated septum, foreign bodies. And let's end with the least exciting part of pulmonology, which is the lung volumes. So in restrictive lung disease, FEV1 to FVC is usually greater than 80. Obstructive disease, usually less than 80. What are those components? The FEV, that's the FEV is the ratio of how much air you can forcefully exhale in the first second over the functional vital capacity. The functional vital capacity is the sum of your expiratory reserve volume, your tidal volume, and then your inspiratory reserve volume, which is to say the max amount of air that can be inhaled after completely exhaling forcefully. So, I mean, that makes sense why the FEV to FVC ratio is important, is because the FVC is your baseline for how much you can inhale forcefully after you've exhaled forcefully. Total lung capacity is everything. It's the vital capacity that we just talked about, plus the residual volume. Just the ERV, expiratory reserve volume, and the residual volume is the functional reserve, or functional residual capacity. And the inspiratory capacity is the tidal volume that we're breathing currently, and then the inspiratory reserve volume. And again, tidal volume is just normal respiration. So, and then AA gradients can be increased in which of the in these following three things: PEs, PEs, PEs. That includes pulmonary embolism, pulmonary edema, and a right to left shunt. That's something that does not improve with oxygen. A normal AA gradient with hypoxia could be either alveolar hypoventilation, or you're at high altitudes. So your AA gradient is said to be falsely normal, because even though your gradient is normal, you're still not getting oxygen in. Going back to sinusitis, you want to give antibiotics if for some reason it hasn't improved after how many days? 10 days. Or if they're worsening 5 days after what was initially thought to be a viral URI. High fevers, purulent nasal discharge and facial pain, you want to give what antibiotic? Amoxiclav. And if they have a penicillin allergy, what do you give? You give Doxy. You can give Moxie or levofloxacin. And if it's chronic sinusitis, you need endoscopic drainage.